Good evening, everyone, and welcome to our panel on COVID-19 vaccine and mask mandates and the human right to health. I'm Jessica Newart, the Rita E. Hauser Director of the Human Rights Program at Roosevelt House, and I'm looking forward to this evening's discussion of these challenging issues, which are very much in the news at the moment, as well as in our courts. As you may have heard, last week, New York City's police union sued Mayor de Blasio over the vaccine mandate that required municipal workers, including police, to provide proof of vaccination by Friday. After a court denied the request to halt this mandate, it has gone into effect today, putting police officers and other city employees covered by the mandate on unpaid leave if they have not registered as vaccinated. And this legal battle is raging nationwide. Last week, 12 states led by Republican governors sued President Biden over his mandate for all federal employees and contractors to get vaccinated. Our courts have largely upheld vaccination requirements imposed by employers, universities, states, and cities. But as we can see, this is much more than a legal battle. To those who oppose vaccine mandates, this is about fundamental human rights and freedoms. And those who support these mandates largely do so on the grounds of public health, fearing the devastating medical consequences of COVID-19. More than 750,000 deaths to date in the United States alone, and more than 5 million deaths around the world. Tonight, we want to explore the health concern driving vaccine and mask mandates as a matter of human rights, the right to be protected from exposure to this deadly virus as part of a larger right to health that has sadly yet to be fully recognized in this country. Eleanor Roosevelt, from whose home we are broadcasting tonight, chaired the United Nations drafting of the Universal Declaration of Human Rights adopted in 1948. This declaration embraces the right to health, which is recognized almost everywhere but the United States. In the context of COVID-19, tonight we want to explore and perhaps try to reframe the discussion of public health as a human right. It is my great pleasure to introduce my colleague and friend, Susanna Sirkin, to moderate this very distinguished panel. Susanna is the Director of Policy for Physicians for Human Rights. She has spearheaded a tremendous amount of work on behalf of that organization, which has effectively brought medical expertise into the human rights movement and made our understanding and advocacy more strategic and more effective. Susanna is often right at the intersection of law and public health, which makes her an ideal moderator for this panel. She will introduce all of the panelists, our own Philip Alkavis from Hunter, Arthur Kaplan, Paul Hunt, and Mahir Mamkad. And I just want to thank all of them for giving us their time and sharing their wisdom with us. Susanna, welcome.
Thank you so much, Jessica. It's really an honor and a privilege to be here with all of you, and especially broadcasting Jessica from Roosevelt House. I'll say good morning to some of you because we know that Paul is in New Zealand, and maybe there's some others on that side of the planet as well. And I want to say that this is going to be a challenging and I hope complex, but also enlightening conversation. To many people, the issues we're about to discuss may seem obvious, but in fact, there are a lot of complex issues that we need to grapple with when we step back and look at this from the human rights perspective. And I would like to say that what I hope we have in the next odd hour and a half is a mandate mashup, so that we really wrestle with the issues and enable those of you who are watching and listening to ask whatever questions are on your mind and any concerns you have as we discuss this crucially pertinent issue that, as Jessica reminds us, is front and center in the city of New York today, but also around the country, but maybe a very different conversation in other parts of the world. And as you say, Jessica, this panel could not be more timely and relevant. And of course, as you noted, it's particularly fitting that Roosevelt House is hosting this event, given its place in history and today as the home in New York City of Franklin and Eleanor Roosevelt, and the locus of the legacy of Eleanor Roosevelt's tireless efforts in drafting and promoting the Universal Declaration of Human Rights, which we'll say for short this evening is UDHR. So I don't like acronyms, but let's use that one because otherwise it's a mouthful, although we say it often. But the UDHR of 1948, which is the basis, as we know, of our global movement to promote and protect human rights today. Now, during this pandemic, we have seen that myriad rights outlined in the Universal Declaration have come into stark focus. The right to life and security of the person, first and foremost. And as this week, we reach the very sobering mark of 5 million recorded deaths due to COVID-19. The right to protection from discrimination in a variety of ways, the right to employment, the right to a standard of living adequate for one's health and well-being, which I'm sure we'll be talking about shortly in the framework of the right to health, which has been vastly elaborated since the Declaration. The right to education, which is part of the dispute around mandates as well. The right to leave and re-enter your country. The right to move within your country. The right to information and to the sharing in scientific advancement, and also the right to benefit, including materially, which is also noted in the Declaration, from cultural and scientific products and work. I mean, right? There's almost everything that has to do with the pandemic in this Declaration, and it's been challenged in so many ways. So we're going to have a conversation about rights and rights versus rights, and rights and responsibilities, about masks, mandates, and vaccine mandates. And while some are labeling this a rights versus rights issue, others are calling this out, that conversation, as if it is rights versus rights, as an utterly preposterous conversation in the context of this pandemic. So we're going to talk about whether there are particular times and situations when rights of some must be curtailed for the rights of the many, even if we want to think about those as rights. But here's also the kicker at the end of the Universal Declaration, which I hope we will talk about because it's not often discussed when we list all the rights that we have and that we should have if we don't have them, but that are out there in this declaration. Article 29, second to the last one, there are 30, says, everyone has duties to the community in which alone the free and full development of his personality or her personality, we will add today, or their personality certainly, is possible. And two, under Article 29, the exercise of their rights and freedoms, everyone shall be subject only to such limitations as are determined by law solely for the purpose of securing due recognition and respect for the rights and freedoms of others. So right there in the Declaration, we have this balance between your rights and everyone's rights. And then there's the last article, Article 30, that says, nothing in this declaration may be interpreted as implying for any state, group, or person any right to engage in any activity or to perform any act aimed at the destruction of any of the rights and freedoms set forth therein. So that could also raise food for thought in this very conversation that we're having. So here's the question we're going to be discussing. Along with rights come responsibilities. So does a mask or vaccine mandate violate individual rights? Or does resistance and failure to enforce mask wearing or vaccination guidance from government result in the denial of rights of others, or even of your own rights? And is this an emergency situation where some rights maybe outweigh other rights? So another additional point I'd like to add, and we'll be getting to it as we interview each of you, as I interview each of you and then open it up for a dialogue and conversation and questions from all of you, is this conversation that we're having about what's going on today in New York City, this week in New York City, even relevant in so many parts of the world where 4% or fewer are vaccinated and vaccines are so scarce, and where the rights conversation might be very different. So before we dive in with our panelists, I just want to lift up a few comments from this past weekend's New York Times letters section that respond to this issue, prompted by a widely read column by Zeynep Tufekci, which asks us to understand more deeply the range of reasons that people resist vaccinations. And I just grabbed a few points from these letters because I think it will stimulate our conversation. One person wrote from Delaware, mandates work. They work well. They overcome ignorance with science. They save lives. Done. However, a primary care doctor in Chicago wrote, this column, which tries to understand the reasons for resistance, is a helpful reminder to me that these decisions often reflect a complex mix of personal belief, fear, misinformation, mistrust, and structural disadvantage that is not easily resolvable. What works? Clearly, vaccine mandates work. As Dr. Tufekci notes, not just because of the consequences to the unvaccinated, but also because of the space-saving way they allow the previously hesitant to receive the vaccine. Paid sick leave works so that people do not have fear of losing their job or income because of vaccine side effects. Addressing structural racism in healthcare works, etc. I'm going to insert a few more of these comments from these Times letters as we go through our conversation, but I'm going to leave it there for now, just to say that we have a phenomenal group of experts here with us today, and each of you brings a vital perspective. What I'm going to do is I'm going to introduce each of you one by one and ask you a question right after I introduce you so that you can open up with your views and your area of expertise. So I'll go from one to the other that way in an order, I think, which will build the complexity of this conversation that we're having tonight, and then get into wrestling a bit and open it up. All of you who are watching, please feel free to post as we go along in the Q&A, and we'll be monitoring those, and we'll open it up for inserting those questions and asking them during the rest of the hour and 20 minutes that we have before us. So I'm going to start with Paul Hunt, who I haven't actually seen in quite a few years, but we interacted a lot as Paul was actually developing the frameworks, the right to health. Paul was the very first United Nations Special Rapporteur on the right to health, or the right to the highest attainable standard of health, as it is formally described. And Paul is probably the world's guru on the right to health. He's made an immense contribution to our understanding of this right. He is coming to us from New Zealand, where he is also Chief Commissioner of the New Zealand Human Rights Commission. He was for quite a number of years Professor of Law at the University of Essex, where he did so much of this work to unpack and understand and elaborate the right to health. So we're going to start with understanding what that is all about. I will also note that on October 15th, and I hope this isn't a spoiler, Paul, you tweeted, "If you are not yet vaccinated, please go for it," demonstrating that you take seriously your rights, your responsibility. So let's go back a few steps. Paul, will you explain to us what does the right to health in international law entail in terms of individual rights, public health measures, and responsibilities and possible curtailments of those rights? And what is the role of government to intervene in a health emergency such as the one we have before us right now? So over to you. Give you several minutes to do this.
Thanks very much, Susanna. A great pleasure to see you again after some years. Can I just very, very briefly thank the organisers, Public Health Institute at Hunters College for organising Jessica, Katerina, and others. And many thanks for inviting me to join you. I really appreciate it. Susanna, look, what I'd like to do is I'd like to go back a step or two, okay? And then you can hurry me along if you need to. But I just want to get some sort of basics in place. Look, there's no doubt that governments have human rights obligations not to do bad stuff, okay? There are definitely human rights obligations whereby governments must not close churches or mosques or synagogues or newspapers or trade unions. You know, there are a bunch of negative obligations on states not to do things. That's clear. What's also clear is governments have human rights obligations to do some things, that is positive obligations. There's no question whatsoever that governments have human rights obligations, for instance, to hold free and fair elections, which are costly, by the way. Governments have human rights obligations to put in place a functioning court system, again, expensive. No question that states have human rights obligations to put in place an effective, humane penal system, which again costs money. So there's no question that governments have human rights obligations of a negative sort, don't do bad things. And also there's no question that governments have human rights obligations to do good things, to take positive steps in relation to elections, court systems, so forth and so on. So then what about the pandemic? So I think it's beyond controversy that there are human rights obligations on government to respond to the pandemic. They have a human rights obligation to take reasonable measures to save lives. That's the right to life. They also have human rights obligations to take reasonable measures to protect health. They also have human rights obligations to provide health care. You know, they must take some measures. That, from the human rights point of view, is incontrovertible. But of course, as you've already intimated, and we're going to be exploring later, I'm sure, is that some of those right to life and the right to healthcare and health protection measures restrict other human rights. And you've referred to that. Those health measures can restrict, for instance, freedom of assembly, freedom of association, freedom of travel, and so forth. So briefly, what one needs in human rights, unquestionably, is a balance. You have to have a balance between the right to life and the right to health care and the right to health protection. You have to have a balance between that and other human rights, freedom of assembly, association, travel, and so forth. And to close my opening remarks here, Susanna, so human rights helps us strike a sensible balance between those rights. And the balance, what human rights requires is that when striking the balance, the balance must be reasonable, it must be proportionate, it must be subject to review, it must be lawful, meaning it's not arbitrary, it's not just made up by health professionals on the spur of the moment. It has to be based on science, not nonsense. And in a modern society, finally, Susanna, in a modern society, we're used to striking these balances between human rights. We do it all the time. We do it every day. You know, my right to privacy has to be balanced with your right to information. So we need balances, and we need to strike these balances sensibly, reasonably, proportionately in the context of the pandemic. So let me pause there in case you have any questions, or I can follow things up later on in the course of the conversation if you so wish.
Let's do a quick follow-up before we go on to our next speaker. I'm just curious if you can explain, based on your understanding of the right to health, whether there are certain true emergencies where a different balance is warranted, and what I know that in the larger human rights world, we're very nervous about talking about emergencies because, you know, a lot of governments use the notion of a state of emergency to curtail human rights. But that may not be what we're talking about here when you're talking about the government obligation to protect the basic right to health of all of the residents of their country, or in the larger world, the global responsibility to protect all human beings.
Yes, look, if in face with the pandemic, if a government does nothing faced with the pandemic, that's a breach of their right to life obligations. It's a breach of their right to healthcare obligations. It's a breach of their right to health protection obligations. That's if the government does nothing. If it does little, too little, that too is a human rights breach. If it does some stuff, but favors some populations and disadvantages other populations, that's a breach. That's a breach as well. So I think that when making these difficult calculations and calibrations, that essential human rights formula, whether it's framed as an emergency or not, is helpful. Reasonable, science, subject to review, proportional, transparent, and so forth. I think that difficult calibration has to be made whatever. And it is complicated because the picture's moving. In other words, here in New Zealand, we use that formula to try and make decisions about what needs to be done. But if one makes the decision this week, one has to revisit it next week because the situation has changed. So it's not just applying the formula once and there we are, bang, got the answer. We have to keep revisiting the balance to make sure that it's sensitive to the latest developments, whether it's deaths or ill health or other matters of that sort.
That's a very interesting and important point. We'll get back to it later on in our conversation, just to note that even in terms of these mandates, until there was free access to the vaccine for everyone in the United States, let's say, one couldn't really argue for a mandate. And so that will be a question we'll be asking later on in terms of what you've just described, Paul, about the evolving and context-specific nature of a mandate. Well, thank you. Great way to start in terms of, and I'm glad you stepped back and looked at the big picture from a right to health point of view and human rights point of view. So now we're going to go from rights to ethics because they intersect, but they also work in parallel and they're not entirely an overlapping language, I would say. And so to unpack that part, because we are talking about both frameworks and worlds in a way, we've just had the guru of the right to health, and now we're going to have the guru of bioethics and medical ethics, Arthur Caplan, who is the director of New York University's Langone's Division of Medical Ethics. He's a very distinguished professor of bioethics. He's written 35 books and more than 800 peer-reviewed journal articles over the decades. And notably, in this context, his 2017 book, Vaccination, Ethics, and Policy. So, Arthur, thank you so much for joining us. And I just, thinking about introducing you, I wanted to just put in another quip from the myriad letters that responded to this column in the New York Times. Somebody from New Jersey wrote, and I don't know if it'll prompt what you're going to tell us or not, because we haven't discussed what you're going to say. But this person wrote, while there are some vaccine refusers who do so out of ignorance, perceived political loyalty, or misplaced fear, I believe that the great majority just object to being told what to do. This sentiment harkens back to Patrick Henry's, give me liberty or give me death. The problem, of course, is that your liberty may contribute to my death. So, I mean, it's actually not funny, but it's an interesting point, especially for the conversation in the United States with some of the legal cases that Jessica mentioned at the beginning. So, Arthur, unpack for us, what do the medical ethics sources and history of mandates or measures that relate to infectious disease have to say? Specifically, let's start with this about the role of doctors and institutions vis-a-vis individual rights to refuse a vaccine and other protection measures, because we've talked about the role of government and their obligations to protect the right to health, let's say, which extends to public health and communities. But we also have this issue of individual doctors and the doctor-patient relationship with hesitancy. And let's talk about, in a human rights concept, a sector of the population that may not, for whatever reason, be able to be vaccinated. And I'm interested in your thoughts about that as well, and how do vaccine mandates guard against those vulnerabilities or challenges?
Thanks, Susanna. And thanks everybody for having me invited to participate in this good, very interesting panel. So a couple of points to make. One, there is a sort of general area where Paul was talking about how the state interacts with its citizens around questions of liberty, what happens if you declare a public health emergency, and whether that can be legitimately declared, which I think self-evidently it can. There can be phony declarations to try and restrict liberty, but I think we all know that the current declarations around COVID with 5 million dead people, it would be hard to argue is not a legitimate declaration of a public health emergency. Under public health emergencies, you can restrict liberties. There are many things you can do. You can quarantine. You can require vaccination. You could ask for masks. You could mandate testing. There are many, many things that would flow from a legitimate, and I'll echo Paul here, reviewable declaration of a public health emergency. But even without that, we also understand at the second level that, as John Stuart Mill continuously pointed out, you can restrict liberty. It's not doing whatever you want to do whenever you want to do it. It is doing things as long as you don't harm others. So when you do things that hurt others, there can be intrusions and restrictions on your liberty. Somehow some Americans seem to have forgotten this when they just run around saying, my body, my choice, or I get to do what I want without restriction. It's patently silly. For example, if I showed up at their house and ate their food because I was hungry, I think they'd resist my intrusion, even if I said, I'm doing what I want to do and you can't stop me. So we have all kinds of restrictions that would fill up more law books than Paul has read or written about what people can and can't do, and why we restrict their choices and their ability to do many things, partly for the comity of civilization, partly because they are, that is to say, they are harming other people. Third point, I consider it utterly bogus to stand up freedom against health in these debates. What you see is if you take public health measures in a pandemic, you create freedom, not taking it away. If I have to stay home or risk death if I go to a concert or some sort of sports venue or merely go into an enclosed space with some other people, then I've lost my liberty because I may die. And I have to be able to go there with some assurance that I'll be able to survive. The notion that it is health versus freedom, where I see the restrictions being most justifiable morally, is when they create freedoms. More of us can go out, more of us can go to restaurants, more of us can wander around and do as we wish if we're masked and vaccinated. That will help us extend our liberties. So it's, to me, it's liberty versus liberty, not liberty versus health or restriction of liberty versus health. You mentioned something, Susanna, which is also very important. Governments have a special obligation to protect the weak and the vulnerable. So the people who can't vaccinate. Colin Powell was vaccinated, the American former Secretary of State and General, and he died. And headlines were out there screaming, Colin Powell dies of COVID. Colin Powell did not die of COVID. He died of multiple myeloma-related COVID complication, meaning he had no immune system. He was vaccinated fully, but it wouldn't work. If you're going to protect him, people who are immunocompromised, people who have HIV, people who have transplants, people who are infants, and I could extend the list, everybody else has to vaccinate to protect them. So when we see school mandates for masking or other restrictions, it's partly to protect the weak and the vulnerable. And many on the podcast will know that this is classic Rawlsian help protect the least well off kinds of an argument that I'm making here, that you've got a very strong obligation to look out for those who through no fault of their own can't protect themselves from whatever the pandemic disease is. I guess the last point I want to make is we've started off talking about human rights and how they would impact what governments can do. There's a separate set of activities, very big in the US, since the US is not always jumping on board the human rights framework, which is what employers can do. And so employers historically, in the US particularly, have had a huge set of discretionary activities they can engage in to protect their integrity of their business or the health of their workforce. And many of the mandates that we see rolling along are coming from private sector employers, even the cops and the firemen of New York City renown, or Chicago, where state employers are mandating. I put through a mandate long before the COVID mandates on flu vaccine for all healthcare workers in New York State, and eventually spread to US and Canada, both. And those were arguments that employers had a duty to protect the vulnerable people in nursing homes, hospice, and hospitals from flu. By the way, got some pushback along the same grounds, but not the ferocity that you've seen people fight back in some sectors to COVID vaccination, which leads me to my last point. Paul said, and I will agree, what we need here is science-based mandates, and we have them. The vaccines work, they're very safe. When people say some of these things are operating under emergency use authorization, that's true, but you've never seen so much evidence for a vaccine working as was accumulated under an emergency use authorization by the FDA in the US. And as we know now, we also have licensed vaccines. So again, some people are resisting COVID vaccine as what I'll call COVID vaccine exceptionalism, meaning there's something different. There is something different about this vaccine. It works better and it's safer. That's what's different about it. So if you're looking to really get into the mandate wars, we've already mandated for school children, many employees, many people who work in places as diverse as astronauts or in the offshore oil derrick industry, or many, many other settings, the military. There have been mandates in place for decades with evidence that's less and with things that don't work nearly as well. So my point here is there's another dimension morally. What can your employer do? What can your employer insist upon? What's the basis for doing that? And, you know, in the US, we're about to have a little bit of a fight about what the federal government can impose by way of safety standards, our OSHA regulations. But we've already seen, and historically have seen, many, many businesses put in safety requirements for their workforce, whether it's having to wear protective gear, or having to take a TB test, or many, many respirators for breathing and many other things. So that line of argument gives private enterprise the right also to impose mandates when they are in the name of the safety of the workforce, or trust that, say, the workforce, when it visits you for sales or to deliver healthcare services, won't kill you. So I'll stop there.
Thank you. Thanks, Arthur. That's a really helpful framework, and your points are very clear and emphatic. I want to get back to in our conversation, just to keep put a pin on this, that to discuss, you know, how does this get transmitted in a context of misinformation and disinformation, and what is the doctor's role to help, or the medical community's role to help overcome the sort of divide that we have of science, anti-science, misinformation, disinformation, or even the politicization of public health and science in this context. So we'll get back to that if you'll jump in later. But right now I want to move to a kind of a different direction by introducing our next panelist, Mihir Mankad. Mihir is the Global Health Advocacy and Policy Senior Advisor at Doctors Without Borders USA. He's a human rights lawyer and has been very active in economic and social rights over many years. Prior to his work at MSF, Doctors Without Borders, he worked at the Center for Economic and Social Rights. And it's really a pleasure to have you join us, Mihir. And you're going to give us perhaps a more global perspective on this issue, because we've been having this intense conversation here in the United States, as there has been in quite a number of other wealthy countries. But we're also in a context in which in so many parts of the world, in the global south, a very tiny percentage of the population has access to the vaccine. And they're looking at this conversation here and going like, oh my goodness, you know, I'm desperate for a vaccine, and you people over there are like arguing about your right not to be vaccinated. Like, what kind of a conversation is that? So maybe you can sort of put us into that environment and how the rights conversation, maybe those people who can't even think about vaccine mandates are thinking about their rights, both governments and people in general.
Sure. Thank you, Susanna. And I just want to start off by, again, thanking Jessica and Katrina for organizing this, and Hunter College for welcoming everyone to this panel. And I'm very, very pleased to be here with everyone else. And an additional small disclaimer so that the long arm of the MSF law doesn't crack down on me. It's just to say that whatever I'll be saying here is or will just be my own thoughts, and nothing should be attributed to MSF. I was given that instruction from up on high, so I better convey it. So Susanna, when we spoke in advance of the panel, you gave me some license to be provocative, and I don't know how actually provocative this is, but I will say that, and as you said, in some ways that this conversation that we're having about vaccine mandates is a parochial one, or even an absurd one for so many people around the world who don't have access to vaccines. And Katrina, I was wondering if you could put up that slide for the moment. Then here we go. Sorry, this will be the only slide that I show, but I thought it would be helpful for everyone to see. So this is, of course, just a visual representation of percentage of people in different countries who have been fully vaccinated against COVID-19. As you can see here, in many ways, this mirrors, different forms of global inequity that we see, whether economic or social or otherwise. And especially across most of the continent of Africa, particularly sub-Saharan Africa, there's almost nobody who's been yet fully vaccinated against COVID-19. Katrina, you can pull the slide down now. That's right. Thank you. Yeah, so that's just to make the point that Susanna had also made, that, for the moment, while I think about 7 billion doses of the vaccine have been administered worldwide, only 3% of people in the poorest countries, or less than 3% of people in the poorest countries, have even gotten one dose of the vaccine. So for myself and for MSF, I can say in this case, the most pressing right to health issue is not about vaccine mandates, it's about access to the vaccine in the first place. And in many ways, this is, perhaps one of them, certainly at this very moment, the most pressing human rights issue that there is, because people, there's no movement really on this front, as far as I'm concerned, insufficient movement by states to share technology, to provide access to vaccinations, to redistribute excess doses that they might have, to ensure that the rest of the world is vaccinated. But that being said, there are some other issues, I think, well, in relation to this in particular, this global vaccine inequity that arise with respect to vaccine mandates in particular places. So obviously, to have a vaccine mandate, you need to have enough vaccines for everybody, or maybe it's not it's to everybody, but you should have enough vaccines to vaccinate everybody. Otherwise, it's pretty difficult to compel people to get vaccinated. And as Paul has indicated, the right to health provides that states, do XYZ different things. There are certain obligations that they have, positive obligations, and one of those is to make available and to provide access to essential medicines, of which the vaccine is one. And without having enough vaccines, the consequences of having a vaccine mandate in place are likely to be that in a country, any given country in which there's vaccine inequity, that the richer and more powerful people who will have access to these to the limited set of vaccines that are in any given place will get them first, of course, and therefore, increase their advantage in that particular society. So, for example, in India, in the early days, the pandemic has not been going on for that long, but in the early days of the pandemic, when the vaccine was first available, there were private sector providers as compared to state public health providers that had access to the mRNA vaccines, the Pfizer vaccine, the Moderna vaccine, and they were administering them, but at like a super high cost. So obviously, India, a country in which there's a huge amount of economic disparity, the poorest and physiologically most vulnerable, the otherwise most marginalized communities weren't getting access to these high quality vaccines. And in most cases, no vaccines at all. Now that situation has changed slightly, but so, simply the fact that there was this inequity, though there was no mandate in that case, but if you can imagine if there was a mandate, it would be much more problematic, that, existing inequities were being exacerbated as a consequence of this general inequity, vaccination inequity. Maybe one other thing to add on this front is just that if there are not enough vaccines, but you have a vaccine mandate in place, and there are certain kinds of ways in which you enforce that mandate, for example, you prevent people from working or accessing travel, or prevent them from accessing certain goods and services. Again, these same communities that are marginalized, otherwise marginalized, will be disproportionately harmed. And within the human rights framework, particularly under the right to health, I would say that this is a sort of a discriminatory action. It is facially discriminatory in some ways, but it certainly has a discriminatory impact insofar as it creates an additional harm to communities that might otherwise be marginalized. So you can imagine, like, for example, a laborer who's working in a construction site or something of that sort, who's mandated to get a vaccine, but the employer doesn't have enough vaccines, the state doesn't have enough vaccines, that if they then can't get vaccinated, they can't work. And the ripple effect of that is pretty significant. So I think that's just another thing to consider. And maybe then the last thing I'll say is that is somewhat to Paul's point about proportionality. I think it's important for us to consider the nature of a state intervention in terms of proportionality when it comes to this, like, where the state is justifying its activity, in this case, public health intervention, that may potentially infringe on the rights of others in some way. And in international law, there's generally a 4-part test that exists to determine whether something is proportional or not. And I'm not going to go into detail into this test right now, but just to say, I think it's a pretty reasonable set of criteria that the state has to meet, or justifications that the state has to make, to determine in that case, the courts to determine whether or not that's an appropriate kind of action, and whether that, in that case, the rights of a particular group can be infringed temporarily, presumably, in service of this other cause, which is, in this case, the public health, resolving a public health emergency. But I think the last thing I want to say, and I'll just kind of leave this out there, is that for me, it's been helpful to think about this, as often is the case in terms of access to treatment, in the context of what happened with HIV, especially around potentially compulsory treatment, mandatory treatment. And in that case, what worked in many parts of the world was not mandating people to get treated, but recognizing people's autonomy, because mandating people to get treated in many cases just led people to avoid going to the doctor to getting treated, because they were, legitimately concerned about the nature of the treatment and things of that sort, being discriminated against because they were from a marginalized community otherwise. And instead, the approach that was taken was to recognize people's autonomy, to work with communities in peer-to-peer education, to, really allay people's concerns about what the nature of what would result from treatment, and then also to combat misinformation and disinformation, which obviously nowadays is a much more severe concern given the nature of social media and the rate at which information is, or misinformation or disinformation, is propagated. So I think it's important to put this in the context of also what's ultimately, so this is a sort of an instrumental argument in a way, but what's most sustainable? Because I'm not sure that coercing people to receive treatment is necessarily a sustainable method of ensuring that as many people as possible are treated, unless we're saying that we want to live in a very autocratic society of some sort.
So you have definitely brought forward some provocative questions, Mira, and thank you for that. And it's very interesting that you mentioned the HIV/AIDS, because our next speaker, Philip Alcabez, who's a professor of public health at Hunter College and focuses on the history and ethics and public health policies over, especially in the context of infectious disease, and has a background also in epidemiology, has written extensively on HIV/AIDS and these issues. And so this really, what you said in your last remarks, Mihir, definitely go right to some of the questions that I wanted to ask you, Philip, which have to do with, is there something very specific about this current pandemic, and how would you distinguish it from previous ones? I know you've written all the way back to, the Black Death and fear and so forth. And certainly there is a context of fear, but there's also, infectious diseases and pandemics can be quite different one from the other. And so I'm wondering if you want to put a point on that or respond to Mihir's points, but also maybe you can help sort of wrap up what you've heard so far before we open the floor to questions. And I see two already in the Q&A, but please, others who are listening and watching, throw in some questions there so we can really wrestle with any of the challenging issues that have already come up. Over to you, Philip, and thank you so much for hosting this as part of Hunter College.
Well, thanks, Susanna. And wow, it's so exciting to be part of this group of what great minds and what a set of questions to take on. So let me see. I'll try to do justice to your question about, is this, are all pandemics created equal? And I guess I would say all pandemics are created equal, but some are more equal than others. And this is the one, this one is very, very special because of the contemporary awareness of political and information issues that is, that shapes the way we are telling ourselves the story of this pandemic. And you mentioned, I wrote a book. It was really a history, going back to the Black Death, of the way the narrative of pandemics has been related through Western history. I don't know if I can do justice to wrapping everything up here, but I want to start with, I really appreciate Mihir's point about the lessons learned through the AIDS pandemic, particularly about inclusiveness. And because that's what I want to talk about here. It seems most relevant to the questions of human rights and to the apparent clashes between rights in the context of public health facing this pandemic. So public health people, I know a lot of them, in my experience, are on the side of the angels. They're kind of like, I might have been a doctor if I had only had the courage to face the sight of blood. Like people in public health want to take care of people, want to eliminate suffering, and really, mostly, by and large, want to see the better world, the one that's more just, and in which access to an optimal optimization of achieving one's capabilities is more universal. And I think this goes to what Mihir is talking about. Is like, can we think about how people far away might go about achieving their capabilities? But, so you knew there was going to be a but. So, but inevitably, in order, both because public health values scientific knowledge, and because inevitably, in order to implement what seems to be best for making the world better, public health has to ally itself with state power. And therein lies a big problem often. And so what I see continually in the public health field is a strain between wanting to make use of state power to implement the measures that seem like they will be best for people, and an ability to listen to what people actually want for themselves. So this pandemic, for me, crystallizes that dilemma in public health. And it crystallizes it at a, this is what everybody here is saying, it crystallizes it at a global level. So we may like to take the idea of liberty and then examine the way rights may seem to bump up against each other, as Paul and Susanna neatly laid out. But we are continually challenged to think about what it means. I sometimes tell my students about this. Isaiah Berlin said this slyly as a quip, but I actually think it was a very deep point that everyone loves their liberty, but liberty for the wolves means death to the little lambs. And this goes to Mihir's point about what does it mean for us, or you didn't make this point, but I won't put words in your mouth, particularly as we're watching out for the guardians of MSF. But so I'll say this: what does it mean for us to say that there's a human rights demand about, say, vaccination, and we could, it doesn't have to be COVID vaccination, measles vaccination, and what does that mean in terms of the capacity of people in other countries to make use of that right, to help themselves in the same way? So that's the first problem. So the first problem is the distress of public health being torn between necessarily aligning itself with the implementation, and really, if you're actually on the side of the angels, listening to what people really want and need for themselves, and in this context, doing it at a global level. Okay, now I'm going to take the risk of preaching to the choir for about 30 seconds, but I promise then I will upset the choir. In this context, the fabulous thing about the human rights framework is the way that it creates this normative basis for thinking about ethics, not just in the old-fashioned way, that old-fashioned American way, but in a way that we can actually universalize, and so that it doesn't seem just like a matter of the sentimentality of people who claim to want the best for others. So that there's a real normative basis here. But to really achieve public health aims, to achieve the just world, we have to add something to that, which is a discursive application, a discursive basis. And this, I think Paul Hunt, this is what you're getting at when you talk about finding the balance between the way that different human rights would require or merit action in different ways. And I would add, finding a balance in a world in which that balance necessarily changes over time, because values change over time, because in an inevitably pluralistic world, the values that people bring to their health and bring to, whatever Patrick Henry meant by liberty, that those change over time, and they're different for different people. And we see this in America. And I think what Dr. Tufekci was saying in that Times piece, which I thought was really good, was there are people who genuinely bring a value about individual liberty to this. They're not necessarily saying, I don't want you to have what you want. They're saying, this is important to me. And that's a kind of crushing dilemma if we want, as everyone here has said, for the world to be able to protect itself. So what I'm saying is that, maybe this didn't upset the choir, but the human rights framework isn't going to be enough if we just take it at face value, and that it isn't, and that the prevention of COVID through vaccination, through masks, through whatever, is also not going to be enough if, in our zeal to implement those measures that seem to make perfect sense, we're not also listening to the other values that people bring to the conversation. And I think that's a really, really vexing dilemma. I don't envy anybody who's a commissioner of health right now to have to solve that in a both reasonable and practicable way. But I think that's what we're looking at. So bravo, human rights. How should we think about the discussion that includes human rights and recognizing values that don't always go with prizing prizing not getting COVID most, that people may have other values, they have other more pressing needs. They may just need enough to eat. I'll be quiet now.
Okay, well, that really puts a lot of issues on the table, and I'm interested to see Paul and Arthur's response to some of the points you just made, Philip. But we have a lot of questions, and we have only half an hour. I can't believe how fast the time has gone, but it's been really an interesting conversation. Definitely challenging and provocative and wide-ranging. But I really want to turn to some of the questions, and some of them are long, so I'm gonna truncate a couple of them just to make sure we get a chance to really answer them and deal with them. So one person has said, I'm pro-vaccine, pro-public health. I believe in implementing public health as a human right, but very concerned about the fact that what the writer describes as the medical industrial complex has a long and ongoing history of directly harming marginalized people. And this person is asking, how often do you seek input from and defer to disabled people on matters of public health when seeking to influence legislation and policies so that they don't have a disproportionate effect on those who are disabled or marginalized by race? And this person is also raising the issue of autonomy and agency and so forth. So this is a big conversation about, for example, the reasonable accommodation in the context of vaccine mandates, but it also points to, I think, an issue which most of you have raised at one level or another, implicitly or explicitly, which is the fact that you can have these mandates. It seems that there's a fair consensus that they're justified along public health lines in the context in which they are widely and freely available, et cetera. But there's still this huge issue around fear, resistance, perhaps lack of understanding, even education in the science and the rationale and the justification for a mandate, and the politics of all of that, or however you want to describe that, the public sentiment around it. And as many people have pointed out, and some of the people in response to Zainab's column, different. We can't really classify people who are anti-vax for whatever reason as one big group, because there are multiple reasons that people have resisted. It's not just one context or mantra or framework. So who would like to answer that? Any of you pop up? Paul, did you have your hand up there? No? Go ahead.
I didn't, Susanna, but I'm going to just make some brief remarks. And it's really fascinating stuff. It's really very interesting. And I'm not going to try and do justice to all the points that have been made. That would be impossible in the time available. But just a couple of points. There's one question in the sidebar, whatever, about disabled people. And I guess and I think it chimes with the point made earlier about inclusiveness. Look, all I can say is that in the context of New Zealand, there's a real, and I can't comment on the United States, others can, but in New Zealand, there's a real, genuine, authentic endeavor to ensure that there's nothing in relation to disabled people. There's nothing, as they say, there's nothing about us without us. That's what they say. So disabled people have to be, disabled people and other people, other disadvantaged individuals and communities have to be at the center of the response to COVID. And just, it's a little tiny indulgence, but on Friday last week, our government announced they are going to establish next year a ministry for disabled people. So as a little indulgence, I just mentioned that. So in the New Zealand Human Rights Commission, one of my fellow commissioners, there are 4 of us, is Disability Rights Commissioner. And so, and she's extremely good and effective. And her passion is to ensure that those with disabilities are at the center of policy making. So that's just one point. I'm not saying that New Zealand has cracked it. We haven't. I'm just affirming that the issue of disabled groups, including disabled people, they must be at the center of this enterprise. That's one point. Second point, Philip, I think you said human rights are not enough. I agree with you. Look, human rights are not a magic solution to immensely complicated questions. There are no magic solutions, but they do provide a lens to help us understand what's going on, but they don't provide neat answers to immensely complicated issues. That's my second point. My third one, I think it was you again, Philip, your remarks were great, was yes, values change, yeah. And look, human rights embody a set of values. Values change, therefore human rights have to change. And that is a great problem and a great challenge. But I don't think we should hide from it. That's my, what number is it, third point? And my last point for now is that in the human rights normative framework, there is an obligation on high-income countries to provide international assistance for low-income countries and middle-income countries. Now, it's contested, of course it is, but nonetheless, there's a strong argument that within the corpus of international human rights law, there is this obligation on states to provide international assistance to low-income countries and middle-income countries, and that obligation should have a high profile. It does place on high-income countries like the United States and like New Zealand to do all that it can to ensure there is a concerted effort to address COVID outside our own jurisdictions. There's much more to say. And Arthur, thank you so much for your remarks too. I haven't commented on them, but that's just because of shortage of time.
Yeah, I can see that we could, thank you, Paul, and I can see that we could go on quite long on any one of these questions, and I have 8 or so now, so I really do want to give the questioners a chance to have their questions come forward. But if someone has what we call a hot pursuit of this particular question, I see 3 hands up among my group here, Philip, Mihir, and Arthur. Could you be brief, and then quickly we'll go on to another question, because there are a lot of really interesting ones here.
So very brief. Thanks, Paul. Human rights changing and human rights coming to recognize and incorporate the specific needs of disabled people. And to that, I would add people who are the neediest in terms of health, people who might not meet the current formal definitions of disabled, but the most elderly. In New York City, we saw this dramatic carnage in nursing homes. So that those people could not be part of the conversation and were not even represented in the conversation seemed to me from the get-go to be a great failure, a great public health failure.
Arthur,
Yeah, so 3 quick points.
quickly.
One, as a person who is a polio survivor and has plenty of disability, I understand the disability perspective pretty well. Been living with it all my life. And I talk to many people with disabilities, and I think the number one issue in the COVID outbreak remains protecting the disabled. As Philip just said, my mother died in a nursing home last year from COVID. Those groups were not protected. They were not looked out for. The rate of death among people with Down syndrome from COVID is about 8 times the average in the population. So to me, the justice issue is not so much are we picking on or burdening the disabled, we're not listening to them enough. And then it is pretty clear that we're not protecting them sufficiently, which is why at this point, masking and vaccination are so crucial, because most of the protection comes from what others do, not so much what they can do for themselves. Institutionalized mentally disabled adults died at the same rates as nursing home residents did in the US, very high rates.
And Mihir?
Sure,
Quickly?
very quickly. Just to say concerning this question about how do we center the most marginalized groups and their autonomy in our work? I think just to say something from the practitioner activist perspective, something that I read the other day really struck me in Kim Stanley Robinson's most recent book, The Ministry for the Future, which is an excellent and amazing novel that I suggest everyone read. But there's a line in it that goes, strategy comes from below and tactics come from above. And I think that's kind of what, I can't speak for MSF because I've only been here for 3 weeks, but that I have tried to do in my work with other organizations and in my own personal life, which is to really generate the ultimate goals and the strategy, as it were, from marginalized communities and those communities that are affected, by putting them at the center of the work, having them direct that. And then, when it comes to the individual determinations about what to do, how to go about seeking change, then not necessarily, it doesn't have to be from the top down necessarily, but that is a tactical question. And then you consider the environment, and the circumstances and proceed from there. But most importantly is being inclusive at the level of strategy when considering what it is you want, and the broad overall objectives of how you might want to get there.
Thanks. So that's a very, very important point. I couldn't agree with you more, coming from Physicians for Human Rights and how we like to think about our work as well. There are a number of questions that talk about public health and the understanding of public health, whether people in the United States, for instance, understand public health, whether they should be taught public health in civics class. Well, we don't teach civics that well either, but along with civics, and sort of amp that up. Is that a thing? And how do people, any of you see what do we think is the future landscape for public health preparedness in the context, having been through this? Let's try to focus on the sort of mandate aspect, since that's the topic tonight, but maybe one of you can take this. And I will add, before we go to that question, just that I put up in the chat, going back to a point that Paul made about government obligation to make sure that there is global access. Physicians for Human Rights and others, including MSF, are part of the People's Vaccine Alliance, which you can look also to this call that we and many, many others, including a lot of Nobel laureates in medicine, I will add, among those calling out for this, are supporting a range of specific points to ensure that wealthy governments, as well as the pharmaceutical industry, do a range of things to make sure that a vaccine is more equitably distributed and widely available. But let's go back to this question about public health. Who wants to take that one?
So Susanna, did you just add, I just want to make sure I understood. I don't know if you want me to answer, but you're asking, should we teach more public health, or I know we should teach more civics, but
I think it's, yeah, the questioner is should we be thinking about how to have more people understand these public health measures, the importance of vaccinations, the role of prevention, et cetera.
The answer to that is so, I'm not going to have it because it's so overdetermined by the way that currently we swim in this ocean of information. And arguably, the people who are supposedly going to be educated in school, that is young people, are most at sea in an ocean of information. And so to me, what we need to do a better job is helping particularly young people, but really everybody, to make sense of this information that they're getting. I know that a lot of the rhetoric in America is about an apparent polarization between, news and fake news, between what's true and what's made up. But to me, there's something much deeper to it which has to do with, can we find a way to engage people, particularly young people, in the question of how, in exactly what way are they a member of the public, and therefore, what does public mean to them? So I think this is very related to the problem of civics. And we can't just say, the government wants you to do this. That's, in fact, if we were to really teach the full history of public health, we would have to teach some of the really dark chapters, the forcible sterilization of the feeble-minded and the mass incarceration of the mentally ill. And that's not going to help us to teach people to think about what it means to be part of the public.
Yeah, so that's a partial answer to the question, a very challenging question that somebody has asked. Following on that, there's also a question about the current political climate, and we haven't really grappled with this exactly. We have talked about the complexity of the reasons that people are hesitant, but this questioner is saying the current political climate in the US and many parts of the world is an important component of rights claims, more than long or deeply held personal values. And it's evident in the US by the breakdown of who opposes vaccines and who doesn't. And of course, this relates to sort of the governor of Texas, and but perhaps not. I mean, we have the police union in New York. I don't know if there's, I assume there maybe is a political breakdown there. I don't know. But what do you all, or anybody who's focusing on the climate in the United States particularly, think about the politicization of this, even along party political lines, let's say? Arthur, do you have anything to say about that?
Yeah, I mean, I track it pretty closely. I'd say just two quick things, because I know we're getting questions in fast. One is, it does make it, for me, more of a mandate issue than an education issue, because the politicization is so deep that people aren't willing to be educated, don't want to have a conversation. I've had this out with some of my friends in the southern states, and I do it in the media off and on, and it's not really an area where persuasion is at the foremost, shall we say, for some of the politics. So that leads me to push harder over on the mandate side than I might otherwise do. I'd like to see us do persuasion and carrots, but I've picked up my stick because of the politics of the whole thing. The other thing is, it does seem to me that this issue is going to be one that is in our politics all over the place. It is not driven by vaccine mandates. It's got abortion. It's got there are many topics that link up to where you are on the politics of different issues in the US. So it's going to take more than just winning the vaccine discussion to tone down the politics.
Interesting. Before we go on to
can I just jump in with one?
Please,
So,
yeah, of course.
Arthur, I really love the point you made earlier about the value of a vaccine mandate in letting people off the hook for not having to make that decision themselves.
It becomes a weird excuse.
Yeah, there have been some comments following that that column that I keep mentioning, saying that, you know, this is actually a relief to many people who are in environments where, for whatever reason or another, their community is opposing it. But I want to go quickly back to community because, Paul, I was going to add this in, but I decided to move on to our other speakers. But in your, I think in the tweets that I saw, but I haven't read more extensively what you've written, you describe a phenomenon or like sort of a cultural phenomenon among the indigenous people in New Zealand about community and about their, as I understand, a value of caring for one another, which is another issue that, you know, we have in the United States and in quite a number of countries, this sort of tension between individual rights and collective rights, if you will. And it goes back to what we started about in the opening of our conversation about rights versus responsibilities, or individual versus collective. And I'm just wondering if you want to share with us a little bit more about, you know, what is going on in New Zealand in groups where they're trying to educate, because quite a number of questions go to this challenge that, okay, we got the mandates, maybe Arthur, yeah, it's the stick, but how do you keep, you know, we still have a very large, given that it's free and available, percentage of Americans who are not fully vaccinated relative to the availability of it and the urgency that most people feel.
Thanks, Susanna. Look, just a few points. In New Zealand, within the New Zealand Human Rights Commission that I work for, we're sort of, in a way, reframing human rights, and we talk about the 3 R's. We talk about the human rights discourse as consisting of the imperative of building harmonious relationships between groups and within groups. So that's the first R, relationships. Secondly, it's a question of responsibilities, not just the classic legal responsibility of the state to comply with human rights, but what we are arguing is that there is responsibility on all of us to do what we can to support each other. There's a human rights responsibility on all of us not to be racist, not to be Islamophobic, and so forth and so on. So that's the second R. It's building harmonious relationships. It's building, ensuring there are accountabilities, not just confined to the state, but we have other sorts of accountabilities to each other and responsibilities, to each other. And then thirdly, there's rights. There is the right to health protection and health care. So thinking of human rights as building relationships and as recognizing responsibilities to each other and as rights, that thinking is partly informed by the sort of the worldview and culture of the Tangata Whenua, the indigenous peoples of New Zealand. And it chimes with what I think Eleanor Roosevelt and others had in mind when they were drafting the Universal Declaration of Human Rights. So that vision, a sort of a refreshed vision of human rights, I think is very relevant in the present context of COVID. Now, finally, I would just add, trying to respond to your point, Susanna, that it's imperative that when we are reaching out to disadvantaged groups, that it's those who are disadvantaged who are reaching out to their peers and fellow members of whatever disadvantaged group it might be. So if we wish to reach Tangata Whenua, that is Maori, the indigenous peoples of New Zealand, then they, in order to do that, and that's what's effective. It's not so effective if I come along and suggest they do it. It's got to be their leaders and their practitioners who do that. And there is evidence that if they have ownership of these interventions, then a lot of the doubts and misgivings fall away.
Yep.
to be for Maori and by Maori.
This goes back to some of the points that Mihir made about really owning the rights and being engaged and feeling agency and feeling heard. And I'll just add that as I was thinking about the Maori in New Zealand and the points that I saw from your feed, Paul, it also brought up one of the other letters in response to that column where somebody wrote in from Arizona about how Native American tribes in the United States have an extremely high rate of vaccination. And the writer says that came from both leadership by tribal governments and a sense of caring for fellow tribe members. And the person wrote, I think this last factor is what's missing for some of us. Too many Americans care nothing for others. The mandates are not there to save the individual. The reason for the mandates is that if you get COVID, you are likely to give it to other people as well. And that is what we must prevent. So it's very interesting to see that in New Zealand, as well as in the United States, Native peoples have really responded in this communal way and gotten their whole communities and tribes vaccinated. I'm going to go now, because we're running short, to a very thorough last question, and then we'll sort of wrap up with a very quick lightning round of any final comments. And this is from Deborah Tolman, who I believe is on the faculty at Hunter. As Dr. Alkavist has laid out, she wrote this right when you finished your opening remarks, Philip. Those of us who believe science, for those of us who believe science, this all makes sense. To those who do not believe in science, it's irrelevant. We know that that the scientific arguments are not compelling to anti-vaxxers of many stripes. So repeating well-supported information and saying it more vociferously doesn't help. We've all tried. So question, how do we engage people who are not swayed by our arguments? And we've talked about that already a bit. How might we take their perspectives and meet them where they are, which is what Mihir has been urging, as well as Paul and others. And how can we learn and respect what their logics are? And are there ways that a human rights perspective can be leveraged? And this is sort of a challenge. And, Arthur has answered it one way by saying, look, let's just, be done with that and do it. And, it's the law and you do it. And of course, I think it's really very relevant, Arthur, that you shared with us that you have survived polio because, of course, many of us remember, I barely do, but before there was a polio vaccine, and certainly in the context of FDR, if he were alive today, he would certainly be enormously grateful for the polio vaccine and would have been the first out there to be vaccinated and tell the entire country that we should all be vaccinated. So anybody want to answer, Deborah, maybe Philip, since.
So let me jump in because I've got to run. I'll make this a double whammy of.
Okay, then we'll say thank you.
Yeah, so just again, 2 quick points. One, I don't think the issue is facts. I think the issue is values, and they may be changing and evolve, but it isn't just to get the facts straight. Too many scientific communicators think if you repeat the facts long enough, you'll convert the critic, and that ain't going to happen. That's not where the fight is. It's a fight about, I'll just leave it at values in the interest of time. The other quick point I'd make is we don't really have a fair fight in terms of getting value points across. There are many conservative news outlets that only people who agree with them are going to watch, and obviously our media is divided along political lines too. So cross communication is very difficult. But one area in the U.S. that's underutilized by, I'll say, progressives is religion. We're a very religious society. If you can recruit religious voices in the U.S., you can make some progress with the other side, I believe. But, a lot of progressives don't really want to turn in that direction. But religion is not anti-vaccine across the board. Indeed, all religious views, in fact, say vaccinate. I mean, all of them. Even Christian scientists believe it's a matter of conscience. They don't prohibit it. So we hear loud voices from some religious circles, but that isn't the messaging normatively that we should really be promoting. We shouldn't be so fearful to ally ourselves when we can get some traction, I think, with our natural allies.
Thank you, Arthur, and
Sorry
thank
to
you so
run on
much
you guys.
thank you for all of your really pointed points and for your enormous expertise in this area and your voice. We really appreciate you joining this panel. And so we have just a few minutes. I don't know, Jessica, if you want to have any closing remarks yourself, but I will just, since we heard from Arthur, let's go around Mihir, Philip and Paul, and then to close out, just got a few minutes left here. Any final thoughts?
Sure. Yeah, maybe just one or two. I think the first is that, we've heard over the course of the last hour and a half how critical it is to ensure that whatever approaches we take, that they're as inclusive as possible of the communities that are most affected. And I think that's essential for the, a number of reasons that I've mentioned, but including those, first of all, from the rights perspective, of course, but also from this more instrumental standpoint, that if we want things to change in the long term, that's really the only way I think that will be accomplished. So that's one. And then the second is just to hammer home this point again concerning the global disparity and what that means. And it's important, of course, for us to discuss vaccine mandates in this forum, and there are very important issues that need to be attended to insofar as vaccine mandates are concerned. But I think we should definitely, of course, bear in mind that in most places in the world, this is an irrelevant conversation in the sense that there are not vaccines to mandate, and in some ways, that's the more critical conversation to have, and the more critical hand to force states who have vaccines, companies who have vaccines, to transfer their technology, to transfer their vaccines, to ensure in the future that the situation doesn't arise, because there's sustainable supply that's decentralized in different parts of the world, that countries can make their own vaccines, the most cutting edge and quality vaccines, so that people do have access to these medicines and vaccines.
Thanks so much, here, and just urge people to, if you're interested in that conversation, look up People's Vaccine Alliance, and you'll see it very prominently on the web and all of the recommendations there. Over to you, Philip.
Thanks. A global crisis requires a global solution, and clearly, this is what Mihir is saying. That's not happening. But also that this is an opportunity for too much of the conversation about COVID has been about public health. And as I've tried to say, that always begs the question of what public am I in? Am I in the same public as you are? And so this is really an opportunity to come back to the value of human rights and the value of a changing, but nonetheless robust human rights discourse is here. That this is an opportunity. This ought to be the opportunity, or I guess I don't want to create an obligation. I wish this were the opportunity for the conversation about coronavirus, about COVID, to be about the universalization of human rights and justice, and giving people access to a decent life worldwide.
Great, thank you. And that really leads to Paul to close us out, having a decades-long perspective on outlining the right to health. What are your thoughts as we talk about specifically mandates, but rights versus rights, if you will?
Thanks, Susanna. Philip, look, I agree with you. Human rights are not enough. They're not enough. They can't solve these things, but they have a contribution to make. And I think that trying to pick up something that Arthur said, if I understood him correctly, it's not so much facts, it's about values. Look, human rights embody a set of values. The values do evolve, but nonetheless, those values are absolutely critical, and they have a universal relevance. And so I think that I would just urge us to understand that there are these very basic values embedded and embodied in human rights, and they're going to evolve, but they can help to make a better world.
You're here. Couldn't agree with that more. And I'm sure everybody on this panel and listening would agree with that. And I will thank all of you enormously. And Jessica, do you want to close us out here? Thank you, Jessica, for inviting all of us and for convening this, and to Katrina, who's also been helping so much, and others on your team, and to Hunter and the Roosevelt House. Really great appreciation.
Thank you, all of you, for such a thoughtful and interesting conversation. I think there's probably 20 panels in all things that you've said, and it's and I think I really appreciate that we've talked a little bit about the global disparity, because we didn't focus on this panel on that issue, but it is obviously right to health that we're focusing on. And I think what Mihir talked about and others have meant is really such a fundamental human rights issue. So I definitely want to just explain that we organize Zenil to look at the right to health in this context, but it is absolutely right, I think, that the global disparity is very central. And they both relate to a right to health that I think, unfortunately, we really just don't recognize in this country. Our effort is to try to promote that and talk about it in the way that all of you have tonight. So I greatly appreciate that. And for all of those who have been listening and given us questions and feedback, we appreciate all of your feedback. We want all of these voices to be heard, and we welcome more voices. And this is not, it's not a first conversation, it's really an ongoing conversation, and it's certainly not the last conversation. So huge thanks to all of you and to Katrina for helping us put together. And we hope to welcome you back to Roosevelt House someday in person. Have a good night, everyone. Thanks.